Mr. Chairman, ladies and gentlemen, let me share with you and a group of really highest expertise in transplantation our first experience in the new project we've started in cooperation with our friends, cardiosurgeons from Institute of Cardiology. Now it had changed a little bit, however, we started in 2018. But the idea was a little bit older. The first combined, that time what was called simultaneous heart and liver transplantation, was performed by Thomas Stardsley in 1984. The patient, Tommy Jones, at that time was 6-year-old. The idea of combined simultaneous transplantations of other organs was vivid that time as well. The example 3 years later, Tabitha Foster, in whom Thomas Stars transplanted 5 organs, survived 6 months. Tommy Jones was operated on in February 1984 in Children's Hospital in Pittsburgh by Tom Stark and his co-workers. The indication to this transplant was familial hypercholesterolemia in very advanced stage. The young patient had high low-density lipoprotein concentration, 10-fold normal levels of cholesterol, and in her history 2 episodes of circulative failure. I remember on the age 6-year-old. This case was later analyzed regarding the role of the liver in cholesterol metabolism, and both scientists, Joseph Goldstein and Michael Brown, received the Nobel Prize in Medicine in 1985. Unfortunately, Tommy Jones died after 6 years after transplant in the mechanism of acute cellular rejection. That's no doubt contemporary that the heart transplantation is the best method of treatment for the patients with severe heart failure. When compare the heart transplant to the left ventricular assist device and pharmacological treatment, of course, the long-term survival is the best for heart transplant, reaching 84%. Recently published multi-center review, which summarized contemporary achievements in combined heart and liver transplantation, precise that the indications have the patients with primary heart disease who experience secondary cardiac cirrhosis, usually caused by chronic hepatic venous outflow obstruction. That deals with the patients with congenital heart disease that required Fontan operation in the childhood. This group is of increased risk of development of HCC in the liver. The second group of patients indications are the patients with hereditary transthyretin amyloidosis that leads to cardiomyopathy. And this third one, patients with primary indication for liver transplant of different origins with concurrent heart disease. As you see here, there is a graph showing the distribution of the centers in the United States that perform heart-liver transplant. As you see, there are not plenty of them. However, the most busy transplant no more than 30 or close to 40 patients in the entire cohort in the particular center. However, the number of combined heart-liver transplants increased through last years. In recent years, obtaining a little bit stable on the phase of plateau. When we look at the indications to combine heart-liver transplant from cardiac indications, of course, on the first place is cardiac cirrhosis, liver indications, and amyloidosis. As a liver indications, of course, cirrhosis with HCV, cryptogenic, alcohol liver disease, and non-alcoholic steatohepatitis. The results of long-term survival, depending on the transplant type, heart alone or hearted liver, is more or less the same. There is no statistically important difference in this group of patients. How we qualified the donors to the transplantation? First of all, we look for the heart allocated donation, then the liver. So the priority is for the heart. For the surgery, the heart implantation, it's like in a single organ transplantation. Then after circulatory stabilization of the donor, the second team enters the operating room and liver implantation is performed like in a single organ transplantation. Our first patient was operated on in the night in August 2018. It was a male of 51-year-old with a classical in this settings indication transthyretin amyloidosis, with, however, a little bit rare when compared to the most popular mutation in the phenylalanine 53 leucine transthyretin gene. Patient with the history of cardiac surgery, with restrictive cardiomyopathy, with stable coronary disease after stent implantation, patient additionally with dyslipidemia and GERD. These are the pictures from that night. Professor Kuśmierczyk from Institute of Cardiology, who performed the heart transplantation. Then we use the system of ECMO in order to stabilize the cardiovascular status of our patient. Then we have changed the scenario and the liver team entered the operating room. That was the aspect of amyloidotic liver. Here are the surgeons preparing liver to the transplant, and we use, of course, the veno-venous bypass that was set by the cardiosurgical team. This is the picture of the liver just before reperfusion, and after completing arterial anastomosis. Here you see the almost finished all the anastomosis, including biliary, and that looked the patient just before taking him from the operating room to the intensive care unit. The immunosuppression was quite classical. We started with the basiliximab, then glucocorticoids, CellCept, and tacrolimus. And through the last 3 years, patient was in good general condition with protocol heart biopsies showing a lack of rejection with normal liver test values. However, we experienced quite usual complications like lympho leak from his inguinal incision. The second patient was young female of 38-year-old. That was also very typical indication as a restrictive cardiomyopathy, complicated with atrial fibrillation, typical cardiac liver cirrhosis with portal hypertension, esophageal varices. Additionally, she developed chronic renal disease, and in her history, ischemic stroke 2 years before the transplant. That's the aspect of the liver after hepatectomy. And this is the liver after reperfusion with the completing all anastomosis in the transplanted liver hilum. Looking back again to the indications, familial amyloidosis, familial hypercholesterolemia, and homozygous beta thalassemia are the most common indications for heart liver transplantation. And when we compare the results obtained by different teams in American literature, you see that the patients and graft survival is good, is high, reaching from 70 to 84% without any special difference between those two groups. In the literature, you see the increasing number of combined organ transplants that deals not only with heart and liver, but also with heart and kidney, heart, kidney, and liver, and other combinations. The number is increasing. These are long-term results of our 5 patients already transplanted. Unfortunately, we have 2 deaths quite early after the transplantation. 1 patient a week, the second almost 2 weeks after the procedure, both due to hemorrhagic stroke, probably from coagulation disorders. In summary, combined heart-liver transplantation is successful and increasing with excellent survival for both cardiac and liver grafts. Outcomes seems to be equivalent to single organ transplants. That there is potential immunological benefit compared with heart transplant alone when we transplant both heart and liver. And obviously, evaluation and decision to proceed for dual organ transplant requires carefully assessment by both teams and at experienced centers to choose the appropriate recipients. Thank you very much for your attention, and there is the picture of the team taking part in the first liver and heart transplantation from 3 years ago. Thank you very much.
Thank you so much, Krzysztof. Question from the floor. Hugo?
Krzysztof, thank you very much for this excellent talk. My question is about the decision to perform simultaneous heart and liver transplantation. I'd like to know what's your experience in performing separate heart and liver transplantation, and if you don't think that, for example, in some cases of cardiac cirrhosis, the heart transplant alone might improve the liver function and avoid the second transplantation.
That's already, thanks Hugo for this question. That's already the question of the debate, because we disqualified the patients from liver transplantation looking at circulatory contraindications. And the same do cardiosurgeons when they sometimes ask us to consult to see the patients they have to disqualify from the heart transplantation because of very high liver enzymes or whatever liver cirrhosis. So once we've met and tried to discuss and to join our efforts and knowledge, and step by step, case by case, we've disputed and we've find out the group of patients that may benefit from our cooperation.
Thank you. Jean-Aimon, have you a question to Krzysztof?
Yes, thank you. Krzysztof, I want to congratulate you for this beautiful work. It seems like you made 2 separate incisions for the case you showed the picture of. We have moved towards having a single incision, and we don't do the final hemostasis until after the liver is done. This has avoided some problems we had with bleeding in the chest cavity while we were doing the liver transplant. So that was one observation. The other, I had a question for you. Have you seen the the beautiful results from Stanford using en bloc heart-liver transplant as a single transplant. It's very interesting approach.
Thank you, John, for your questions. First of all, I appreciate your advice. I think we have to check our. That's needless to say that step by step, gaining some experience with consecutive patients, we modify a little bit our technique and our approach. Of course, answering for your second remark or question, of course, I know that they do quite a modern, independent way of technical implantation, but frankly, we did not yet analyze it if we like to adapt it to our settings. But why not?
Question from
I have a
Wojtek.
question. How many patients you have on your waiting list for now?
Good questions. One patient is still waiting, but there are kind of a queue to be assessed. Due to some legal or administrative problems, we have to suspend a little bit our activity, but I hope that will come back soon.
My congratulations.
Thank you.